Hi again. So I'm Colin Ross, psychiatrist, grew up in Canada, did medical school, psychiatry training, practiced as a psychiatrist, moved to Texas in 1991, and I've been practicing in the great state of Texas ever since. I've had a hospital-based trauma program in the Dallas area since 1991 that's still operating. Had for 20 years programs in Michigan and LA, and last couple of years been living in the Austin area and have a partial hospital program, intensive outpatient program in the Austin area. 260 or something papers in peer-reviewed journals, 35 books, one of which is Trauma Model Therapy, and Naomi Halpern is a co-author on that. And I'm going to talk about one of the concepts from Trauma Model Therapy, which is addiction is the opposite of desensitization. So this is a general idea, perspective. You can take it in all kinds of different directions in terms of techniques and strategies. So it's more a general orientation, but it does lead to specific things that we do in treatment, which I'll describe. And basically, it's a way of rationalizing art therapy, music therapy, all kinds of experiential therapies. So what is addiction in this very compressed version of this way of thinking? Addiction is an avoidance strategy. And we can get off into how much is it genetic and this, that, and the other. But its function or its purpose, from my point of view, and Naomi agrees with me, at least she pretends she agrees with me, is it's an avoidance strategy. You don't want to deal with this and that on the outside, all these people, all the situations, the boss, the finances, the COVID epidemic, or stuff on the inside. Memories, feelings, conflicts, bad thoughts, bad beliefs about yourself. So, glug, 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 don't have to worry about that anymore. So all addictions, whether it's drugs, alcohol, eating disorder, or sex addiction, the whole broad palette of addictions are all basically avoidance strategies. They take you from here to over there. Here is where you are now. This bad situation, bad feelings. Over there is anywhere except here. Stoned, wasted, passed out, distracted, dopamine cranked up, whatever it might be. So basically addictions are transportation strategies that take you from here to over there. What we want to do then is say no to your addictions, which is make this really for real deep commitment to doing the work of recovery, which means now the journey starts. Doesn't mean the work is done. But without that very deep for real commitment, well, you're never really going to get started. You might talk the talk, but you won't walk the walk. So you make that really for real commitment to doing the work. And then the next step is you turn around and start facing and dealing with what you've been avoiding. So you're coming back at the bad feelings, the conflicts, all these things. So addiction is the opposite of desensitization. And desensitization can be kind of divided into two broad subgroups, which is systematic desensitization, which is little steps, little steps, little steps, little steps. Or in the PTSD literature, it's called several different things. It used to be called flooding, which doesn't sound like a very good thing, so they kind of dropped the word flooding. Now it's prolonged exposure or exposure-based therapies. In the American Psychological Association, in their treatment guidelines for PTSD, they give the thumbs up to CBT and prolonged exposure as the evidence-based treatments. And they're kind of about EMDR, they kind of half accept that it's effective. And then if we get to any kind of psychoanalytical therapy, it's not up here with the evidence-based stuff. That's the attitude in academia. Okay, that's fine. So who are the people in the research studies who are given courses of prolonged exposure where the PTSD symptoms come down? Well, they're not in prison, they're not homeless, they're not dead from overdoses, they're not inpatients in psychiatric hospitals. They have to be fairly organized, functioning people, a lot of them undergraduates, who come into the university, fill out the paperwork, 1, 2 weeks, 6 weeks, 8 weeks, 12 weeks. So that's a select group right there. And it doesn't matter really if it's full PTSD or partial PTSD. or even if it's just phobias or depression or whatever the treatment might be for whatever disorder, most of the literature is on relatively cooperative together outpatients who come to appointments, and you don't have to call security every time they show up. Well, that's fine, but that means it's not generalizable. That means that, okay, in this group of people here, this little small subgroup, prolonged exposure works great, or CBT for depression or whatever it might be. What about the people that I deal with? Highly disturbed, huge trauma histories, many, many different disorders and diagnoses, years of therapy required. It's a whole different ballgame. You can't treat these problems with 8 sessions of CBT. If prolonged exposure means talk about it, think about it, even use virtual reality goggles sometimes to put yourself back in combat, or put yourself up in the big elevator on the outside of the building if you have a height phobia. So talk about it, relive it, imagine it, talk about it, relive it, imagine it. And if you do that enough, by sort of extinction or some unknown mechanism, the intensity, the charge of the PTSD settles down and the symptoms go into remission, which actually works for one car wreck, one assault, one fairly simple trauma in adulthood. So therefore it's evidence-based, and it's right there with CBT. What happens if you try to use prolonged exposure with severe chronic childhood trauma survivors? Complete disaster, meltdown, flooding, addictions cutting all over the place to try and self-regulate and bring yourself back down. So prolonged exposure is not just unhelpful with severe chronic complex PTSD, dissociative disorders. It's actively toxic and contraindicated. Oh, but not if you're in academia working with the college students on your treatment guidelines. So we don't do prolonged exposure, memory work, flooding, focusing on the memories at all. We do lots and lots of self-regulation skills, grounding, if it's a complex dissociative disorder, orienting the parts to the body in the present, getting the system communication going, forming a team on the inside, getting out of the current battering relationship. Why do you want to start doing memory work with somebody who's getting beat up by their husband every week? So we do systematic desensitization, little step by little step by little step. And there's all kinds of different ways you can do it. And the focus could be on anger, sadness, anxiety, emptiness, boredom. So in the inpatient setting and in the outpatient setting, we have kind of an office set up where we can make some noise. And we have a board on the wall, and we throw what are called hacky sacks in the US, these little sort of balls about this big that have kind of like beans inside or something. Throw them at the wall. They don't make a mess, they don't splatter. So you're the guy or gal who's working, you're throwing at the wall, you're getting a little bit of adrenaline up, you're getting a little heated up, and you start yelling about what you're angry about or yelling at who you're angry about. So you really get revved up. Well, great, what's the purpose of that? People come to therapy so they can get angry and yell and shout. How does that help? Well, there's a whole rationale behind it. Because some people are like, okay, I'm ready, I'll work in group, I'm ready to get angry. I get angry all the time. Then we do anger management, but the person's yelling at their mother or their father, I hate you, you this, you that. And then the therapist goes, now tell them I couldn't make you love me. I couldn't make you, and then now come the tears. So that's a simplified version of what it takes. But when somebody's too much in the anger, we want to flip them over to the grief because they're avoiding the grief by hiding in the anger. Excuse me. If they're all depressed, no energy, down and out, we want to get them in touch with their anger, get the anger up and running because it's energizing, it's normal. We do all kinds of validation, teaching about fight, flight, freeze. You didn't have the option to not get angry, your body just did it. If the person's religious, we'll say that's God's design for how the body works. If not, we talk about evolution, survival advantage for it. So we're cognitively normalizing, which is the beginning of desensitization. We're educating. We're learning all kinds of self-regulation skills. We're making the commitment to saying no to your addictions. But we want to get the anger up and running. So it's not just this arid intellectual exercise. It's not like, okay, class, what could we do when we go home and we get angry? I could go for a walk, I could this. That's all good to have a list of strategies, but nobody ever learned how to ride a bicycle by reading a book. You got to get on the bike and practice. Same with this, affect regulation. You got to practice it with the affect up and running. So then it's a sort of sheltered workshop to actually practice these self-regulation techniques with the anger, another group, the sadness, the fear, actually up and running, but not so intense that the limbic system just flooded the cortex and the cortex is offline and they think that you're the perpetrator. So you got to stay grounded enough that you're cognitively processing and learning, but with the affect intense and up and running at the same time. And then this has two purposes. One is, it turns out that you're taller than you were when you're 7 years old. And that huge ball of black anger that was this big and filled the whole universe, now I'm looking at it from 5'6", it looks kind of smaller and more manageable. And it's been validated, so I don't have to phobically avoid it so much. I don't have to hate myself because I'm angry. Therefore I don't have to squash it down. When I squash it down, it leaks out the side all over the place. So that's the affect management skill building. It's also the desensitization. Okay, I'm really angry now. For some reason, these therapy people don't have any heroin available for me to shoot up. They won't let me bang my head. I can't get online and search around for whatever online. So I actually have to back out, settle down, self-regulate. So that's the practice part. But now I get back to, I'm kind of okay again. Hey, wait a minute. That anger's not so unmanageable as I thought. I'm now learning that it's not evil, abnormal, it's normal. I went into it and I backed out. And there's all these like other weird people in the room saying bizarre things like, good work, we're proud of you. Whereas when I was a little kid, if I showed any anger, kapow, I got it even worse. So I had to learn that my anger is a threat to my survival. It's toxic. And I sure learned that everybody else's anger is toxic and a threat to my survival. So it's a whole relearning experience. Okay, now my affect management skills are better than I gave myself credit for. I've learned something here. Now I can go in a little further, back out, a little further, back out. So that's the rationale for all these different experiential therapies. It's sure nice to feel your feelings, because it's not nice to feel overwhelming fear, anger, terror. It's a practice, self-regulation, desensitize. So it's really no more mysterious than your basic behavioral desensitization of anything. A little more complicated, a little more painful, a little more difficult, takes longer, but the same basic principles. So that's why I say, and Naomi seems to agree, that addiction is the opposite of desensitization. It's a principle that we use all the time in therapy. So thank you for listening.